Good morning to everybody. Glad to be here. I see here a lot of friends. Thanks for coming. And I hope that this one is moving somehow. Okay. Yes, yes.
Yeah, it's working.
Perfect.
You have to press here and the laser is here.
Okay. These are my disclosure. For research purpose, we are using ultrasound equipment of several ultrasound companies. And all systems, they have advantages and disadvantages and limitation. Shear wave elastography is available on the ultrasound equipment of several companies, and it has been accepted nowadays for the non-invasive assessment of liver fibrosis by clinical guidelines. Shear wave elastography can safely replace liver biopsy. And this is particularly true now that for chronic viral hepatitis, we have the availability of very effective drugs. For chronic hepatitis C, it is possible to eradicate the virus in 90% of cases, but also in chronic hepatitis B, very powerful drugs are available. And non-alcoholic fatty liver disease is now a major health problem. The rate of the disease is is an health problem with 30% of patients affected by non-alcoholic fatty liver disease. It's an umbrella that goes from simple steatosis, is not a disease, up to necroinflammation, and in case of necroinflammation, there is also the possibility to liver cirrhosis and complications related to liver cirrhosis, hepatocellular carcinoma, portal hypertension. And recently, an interesting study has been published, and it has shown that in patients with a non-alcoholic liver disease, it is the presence of steatosis and significant steatosis is linked to liver fibrosis. So the quantification of the fat in the liver is very important. And for the quantitative assessment of fat in the liver, non-invasively, we have the proton density fat fraction by magnetic resonance, and this is accepted nowadays as the reference standard, the gold standard, because it's a non-invasive procedure that is not operator dependent, and results and comparison with liver biopsy is an excellent one. And also the availability of controlled attenuation parameter. Controlled attenuation parameter is available since 9 years on the FibroScan device. It needs a dedicated device, no image is obtained. And all the studies that have been performed using the CAP have shown that there is an overlap between consecutive grades of liver steatosis. Nowadays, it is possible a multi-parametric approach using ultrasound system. We have the B-mode image, but we may obtain several parameters with the same equipment. The Doppler, contrast, elastography, attenuation imaging for the quantification of liver steatosis, and the dispersion related to inflammation. My talk is focused on elastography and the attenuation imaging. And we can have both assessment using the Canon system. And as you can see, when we use elastography, here we have together with the color map, the propagation map. And this is the image of the attenuation. It is a very large box, and the measurement is performed in a large area. What is the advantage? Looking, we have to understand what is the accuracy of this technique, but one of the advantages respected to CAP is that having the color map, it is possible to choose the area where to perform measurements, and an area without artifact. It is not possible using the CAP. And on the report, we have all the measurements that have been performed, as you can see here, for shear wave elastography, and results are reported either in speed, in meter per second, or using the unit of the Young modules in kilopascal. And several other parameters are reported as well. And we have here the dispersion, the attenuation, and on the report we have to use the median value either of the speed or the elasticity, together with a quality factor that has been recommended by the guidelines. All the guidelines published for shear wave elastography is the AQR divided by median. This is a quality factor and should be less than or equal to 30%, 0.3, when we use the Young modules. And the World Federation guidelines have recommended for the speed quality factor up to 15 or 0.15. And here, excuse me, here you can see also a visual assessment of both the shear wave, the dispersion, and the attenuation imaging. For the attenuation imaging, we don't have yet the cutoffs, but we are performing and have concluded a few weeks ago a study. The data are being analyzed. And when we use SWAIN, our daily routine, we have to know that shear wave elastography can be performed with the FibroScan device. Is a shear wave elastography technique. Is a device dedicated, without image, dedicated to the assessment of elastography, or the ultrasound equipment, either point shear wave or two-dimensional shear wave elastography. And all the studies that have been performed using shear wave elastography on the ultrasound equipment, they have shown that results are as accurate as those obtained with the FibroScan device. And in some studies, the accuracy is even higher. For sure, there is a higher applicability of the technique. And using shear wave elastography in our daily routine, we have to keep in mind that the assessment is of the stiffness of the leva, and is a virtual palpation. The stiffness may increase for factors that are not related to leva fibrosis. So there's a direct correlation with the leva fibrosis, but other conditions may increase the stiffness. These are confounding factors. The necroinflammation, acute hepatitis, they all increase the stiffness because there's an increase of fluid in the liver. As it happens in case of extrahepatic cholestasis because of the bile, increase of the quantity of bile in the liver, or after eating because there's an increase of the portal blood flow, and in congestive heart disease because of congestion of the liver. So it's important to exclude all these confounding factors when we perform and give the results. And from a technical point of view, also the inspiration is important, because in deep inspiration, the liver is pushed down, so there could be an increase of stiffness. Usually when we perform elastography, we ask the patients to breathe normally. Instead performing a B-mode ultrasound, we ask the patients to take a deep breath. And then when we have chosen the area where to perform the measurement, we tell the patients to stop breathing at mid-expiration. And unfortunately, the results obtained with the several ultrasound equipment, of different companies, they do not give the same values. This is a study that has recently been published, and the FibroScan was used as the reference. In this study, we used the 6 ultrasound equipment with the shear wave elastography, and 2 of them had two-dimensional shear wave elastography. We didn't, all the systems are anonymized. Even here, the system are anonymized. The 2 ultrasound systems that were used were the supersonic system and the Canon system. And as you can see, the agreement of both systems with the FibroScan value was pretty good. And the cutoff values are is not possible to use the same cutoffs for every equipment. So we have to refer to cutoff of that system, and also are not the same for all the etiologies of liver disease. It is important to refer to cutoff values also for the etiology, and we obtain a number. This number should be interpreted by a liver specialist, and should be interpreted taking into account the clinical history and lab data of the patient. For those of you that are interested, there is an update of the European Federation for Ultrasound and Medicine and Biology guidelines. These guidelines are available for free on the EFSUM website or on the website of the Ultrasound Medicine Journal. And also the update of the World Federation guidelines is available for free. You will find in these guidelines not only technical information, but also clinical information. And for the different stage of liver disease and different etiology. It is important to have a guide when we perform a measurement with a system. And I have to say that Canon has a very reliable guide, and this is very important, the propagation map. Measurements should be performed when the lines are parallel and are at the same, there is a same distance between consecutive lines. This is very important because when we follow this criterion, the measurement is always reliable. And you can see here a case of no fibrosis, significant fibrosis, and cirrhosis. The distance between the lines increases with the increasing of liver fibrosis. But measurements are performed in areas where the lines are parallel. And this is just to show where we have to put this round circle. It's better, we look usually when we perform elastography using this system, we look at the color in the sample box to have a sample box filled with the color. But when we want to perform the measurement, we don't look at this anymore, but at the propagation map. And here you can see that in the bottom, the propagation map is not a good one. Here the same on top and the bottom is not a good one. So we choose this area. Here or here the same. On the bottom is not a good one, even if here the sample box is filled with color. So using only the color inside the sample box is not enough to choose a reliable area where the measurement should be performed. When the lines are not parallel, the reliability of the data is low. So the suggestion is to not perform measurements if you obtain an image like this, even though here is filled with the color. And here you can see that looking at the propagation map, we can exclude completely this part of the sample box. The same in this area. So in this equipment, the propagation map should always guide your measurements. We have performed in the past Concordance study using the propagation map as a guide in a small series of the patient. The FibroScan was used as the reference standard, and because it's a validated technique. And you can see here at that time we used the Applio 500 system in 61 patients. And the measurements on this system were at that time performed using the median value of 10 acquisition. And patients fasting in supine position, resting respiratory position, the ROI for measurements at least 1 centimeter below the Glisson capsule, and avoiding large vessels. This protocol is valid for all the shear wave elastography techniques. And protocol for this system, for two-dimensional shear wave elastography, to have the simultaneous now is by default, we have a simultaneous display of the color-coded image and the propagation map. The reliability of the data always verified looking at lines, and the ROI for measurements at least 1 centimeter. This is recommended now also by the guidelines. And on the still image, use the propagation map as a guide. Also, I strongly suggest, and guidelines have now suggested, that only one measurement should be performed in a frozen image. The statistical analysis was performed using the concordance correlation coefficient. This is statistics that takes into account both the precision and the accuracy. And concordance is excellent when the value is above 0.81. And these are the results that we have obtained. They are showed using the violin plot, that is an estimation also of the density of the data at different values. And as you can see, the values obtained, there was not a statistical difference between the values obtained with transient elastography and those obtained with two-dimensional shear-wave elastography. And the concordance was an excellent one, 0.85. And I want to underline the concordance at this stage up to 12 kilopascal. That is the cutoff value for liver cirrhosis. As you can see, here the data were grouped and similar to the data obtained with the FibroScan device. Whereas for higher values of stiffness, you can see that there's a dispersion of the data. This is true not only for the Canon system, but for all the techniques available in ultrasound equipment. And there is an explanation for that, and this is the difference in the push. Using the FibroScan, the pushing is made on the screen, on the skin, whereas using the ultrasound equipment, the push is made directly on the liver. And this is another way to show the data using the Bland-Altman plot. And here you can see the same, that the data are very close to the values obtained with the FibroScan device. These results have been confirmed in a multi-center study at which we have, our group has participated in almost 600 patients, and you can see the same. The data were similar, the values to those obtained with the FibroScan device at lower values of kilopascal. And this is in another study, the same results. So in the three different and independent studies, the same result was obtained. High concordance up to at least 12 kilopascal between the two-dimensional shear-wave elastography on the Canon system and the FibroScan. And then we performed a pilot study and accuracy study in patients with chronic hepatitis C, in this case using the FibroScan as the reference. And for the cutoff values of the FibroScan, we used those of a meta-analysis, 7, 9.5, and 12 kilopascal for staging of significant fibrosis, severe fibrosis, and liver cirrhosis. We performed on the same day measurements with the Canon system and the FibroScan system, and the Applio system and the FibroScan were used by two independent operators in random order to avoid any bias. These are the results obtained in our series of patients, and we tested again the correlation, the agreement between the two techniques, and it was confirmed an excellent one. The median value obtained in our series, as I said before, for liver cirrhosis with the two-dimensional shear-wave elastography, a lower value respect to transient elastography. The violin plot for each stage of liver fibrosis And these are the cutoff values that we have obtained in our series. As you can see, sensitivity and specificity were pretty high, and accuracy, looking at the ROC curves, is almost 1, very high accuracy of the technique in staging liver fibrosis. The accuracy study has been tested also in a multi-center study. I hope that the study is available soon, is published soon. And again, we use the Diablo system and transient elastography as in the pilot study. The majority of patients were patients with the chronic hepatitis C. 2/3 of patients had the chronic hepatitis C. It was confirmed a high accuracy of the technique in staging liver fibrosis. And how many measurements do we need to obtain a reliable and accurate value? In this study, it has been shown, comparing 5 to 10 measurements, that 5 measurements is enough, and we have to use the median value of 5 measurements. And also in another study published last year in a series of 55 patients, the same result has been obtained. 5 readings were equivalent to 10 readings. So we may stick to 5. On the other hand, in the updated guidelines of the World Federation, we have recommended 3 or 5 measurements when a quality assessment parameter is used. And in the case of the two-dimensional shear-wave elastography available on the Canon system, we have the propagation map. And we have to stick to this very important and very reliable quality criterion. On the Canon system is now available the attenuation imaging. It is possible using the attenuation imaging, the ATI software, to quantify liver steatosis. It's based on a quantification of the attenuation in decibel per centimeter per megahertz. And the system automatically filters structures like the vessels or strong artifacts. They are not included in the calculation of the attenuation coefficient. So if we have some vessels inside, the sample box is not a problem. And this is some of our patients in our study. We have compared the results obtained with the ATI to the CAP. And in case of no steatosis, mild steatosis, or severe steatosis, there is an increase of the value. The results, the total, the number is different, because the CAP gives the value in decibel per meter. Instead, we have here decibel per centimeter per megahertz. So theoretically, this value is not affected, is not affected by the frequency of the probe, as it happens when we use the CAP that has 2 probes, the M and the XL probe, because this value doesn't take into account the frequency of the probe. We have performed a repeatability study to understand what is the agreement between measurements performed by different operators. And as you can see here, we use the concordance correlation coefficient in this study like we did before. The overall agreement between measurements performed by two different operators is very high. And the intra-observer and the inter-observer agreement, they were both above 0.90, so it's a repeatable technique. And also I will show you the results of the concordance study. And we have investigated the concordance between the attenuation imaging and the proton density fat fraction obtained with magnetic resonance, that is nowadays the reference standard. And the result is very good. The correlation is above 0.80, so the technique should be, we will see in the near future, but seems a reliable technique, a repeatable technique, and hopefully also an accurate technique. So the advantages of a multi-parametric approach is a single one-stop comprehensive ultrasound examination. It is possible combining various ultrasound imaging parameters to improve the diagnostic accuracy, and this approach is cost-saving in a diagnostic workup of patients with chronic liver disease. I thank you very much for the attention.